Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. Today we're going to talk about cancer drugs. Many of you are intimidated by these medications. They have funny names, difficult to remember mechanisms of action, and only a handful of you will prescribe them with any frequency. So there's a tendency for students to just give up on learning about chemotherapy. But I want you to rid yourself of this defeatist attitude. Come into this lecture with a chip on your shoulder. Don't let those puny chemo drugs back you down. You show them who's boss. Methotrexate, more like methostupidate. And tell 6-mercaptopurine that its mama is so old that when told act her age, she died. And you know 6-mercaptopurine doesn't like anyone talking about its mama. And because I'm a gentleman, I won't even tell you what to say to 5FU. So sit up straight, stiffen your upper lip, flex those muscles. It's time to fight some cancer. So let's get started with an overview of chemotherapy in cancer. So chemotherapy is the treatment of cancer using specific chemical agents or drugs that are selectively destructive to malignant cells and tissues. Now, approximately 40% of the population will be diagnosed with cancer in their lifetime. And cancer is the second leading cause of death in the United States, with the first being cardiovascular disease. Now, cancer treatment modalities include surgery and radiation for local control, and then, of course, chemotherapy for systemic control. And between 50 to 75% of the people with cancer will receive chemotherapy in some form. Now, cancer is caused by a loss of normal regulation of cell growth, differentiation, and apoptosis. The goal of chemotherapy is to cause a cytotoxic event to inhibit this uncontrolled growth of the malignant cells. There are various mechanisms of action that are used in chemotherapy to interfere with cell growth. And because these drugs are targeted at cell growth, the cells that are dividing and replicating are the ones most affected, which is why it works in cancer. Now, those not dividing are less effective. These non-proliferating cells are in the G0 phase of the cell cycle, and the effectiveness of chemotherapy is highly dependent upon the cell cycle and tumor growth. And the growth fraction is the fraction of tumor cells that are actively replicating. The higher the growth fraction of a tumor, the more susceptible it is to chemotherapy. Now, a good example of this is comparing a Burkitt's lymphoma to an indolent follicular lymphoma. Now, Burkitt's lymphoma is a highly aggressive, rapidly growing cancer. The downside is that if left alone, it progresses quickly, and if not treated, will lead to a quick death. Now, the upside is that it's highly sensitive to chemotherapy and can therefore be cured with chemotherapy alone. On the other hand, a low-grade follicular lymphoma, which is indolent, is slowly growing and can go untreated sometimes for years without causing symptoms. But it's much less sensitive to chemotherapy and therefore not typically able to be cured. Now, we've also observed that early on in tumor growth, the rate of growth of a solid tumor is much faster, but slows as the size increases. The larger tumor size, the increased distance between the center of the tumor and its access to nutrients and oxygen frequently causes the necrosis of the center of the tumor. So this observation has led to the development of new drugs directing at cutting off access to these nutrients via limiting the tumor's ability to effectively vascularize itself, which is called anti-angiogenesis. Now, there are a number of strategies in the administration of chemotherapeutic drugs used today. Now, chemotherapy may be given with a curative intent or may aim to prolong life or to palliate symptoms. Now, combined modality chemotherapy is the use of drugs with other cancer treatments, like we talked about before, such as radiation therapy or surgery. Now, most cancers are now treated in this way because combination chemotherapy is similar practice that involves treating a patient with a number of different drugs simultaneously. Now, the drugs differ in their mechanism and side effects, and the biggest advantage is by minimizing the chances of resistance developing to any one agent. You use more drugs, usually cancers can't be resistant to all of them at once. Now, in neoadjuvant chemotherapy, and this is also known as preoperative treatment, the initial chemotherapy is designed to shrink the primary tumor, thereby rendering the local therapy, like surgery or radiotherapy, to be less destructive and more effective. So you shrink down the tumor, and therefore when you take it out, there's less to take out. Now, in adjuvant chemotherapy, so this is called postoperative treatment, This can be used when there is little evidence of cancer present, but there is a risk of recurrence. So this can help reduce chances of developing resistance if the tumor does develop. It's also useful in killing any cancerous cells which have spread to other parts of the body. This is often effective as the newly growing tumors are fast dividing and therefore very susceptible. And then palliative chemotherapy is given without curative intent, but simply to decrease tumor load and increase life expectancy. And for these regimens, a better toxicity profile is generally expected. You want people to feel better if you're not going to give them a realistic cure for their disease. Moving on. So chemotherapy is typically dosed based upon body surface area. And so a calculation based on height and weight is given, and then chemotherapy is given in cycles. So for example, in treating a man with metastatic non-small cell lung cancer, he may be treated with carboplatin and paclitaxel. So you would give this once every 3 weeks for a total of 6 times. So in this situation, the cycle is a 3-week cycle, and he'll receive 6 cycles. Now, this is because chemotherapy's effect on cancer cells follows a first-order kinetics. So this is a given dose of drug kills a constant fraction of cells, and this is called a log kill. So remember that constant fraction of cells. So after each cycle or dose given, there is a log reduction of malignant cells. But some survive. So this is repeated in hopes of catching the remaining cells in an active dividing state. Now, unfortunately, there are what are called sanctuary sites in the body, where malignant cells find sanctuary because of natural barriers to drug exposure. Now, this results in prevention of chemotherapy access to these sites. So the central nervous system is protected by the blood-brain barrier, so that's a good example. The testicles are another site where there's a natural barrier. So diseases in these areas may require a different approach than cancers in other areas. Now, frequently, combinations of chemotherapy are used to target multiple growth pathways at once, which hopefully increases the cell kill without significantly increasing toxicity and allow for effective treatment against a wider array of cell lines. Now, combination therapy will also hopefully decrease or prevent drug resistances, and tumors may acquire resistance to chemotherapies after a period of time due to mutations. So multi-drug resistance, unfortunately, still can develop. However, this is usually a result of amplification of a permeability glycoprotein or P-glycoprotein. So remember that P-glycoprotein is a very common resistant mechanism that cancers can use. And this is specifically an ATP-dependent pumping of the drugs out of the cells. So this P-glycoprotein actually pumps the chemotherapeutic drugs out of the cancer cells. Now, also unfortunately, chemotherapies also affect normal cells which divide rapidly. So remember how we're killing our cancer cells with these drugs because they divide rapidly? Well, we have normal cells that divide rapidly as well. So these include cells of the mucosa, bone marrow, and hair, which explains the usual side effects of these treatments. So mucositis, nausea, vomiting, diarrhea, bone marrow suppression, and hair loss. Now, treatment dose is frequently limited by these side effects. And much effort is put into controlling the side effects to make treatment and chemotherapy tolerable. Now, supportive care in cancer patients has improved drastically over the past 20 years. Many drugs have been developed for the specific purpose of improving quality of life for patients treated with chemotherapies, and we'll discuss some of this later as well. All right, let's move on to the drugs now. So as we talk about each of these chemotherapies, we'll discuss their clinical use, their mechanism of action, their mechanism of resistance, and then, of course, their side effects. And many of these are going to have similar scenarios in all of these categories. So the first category are the anti-metabolites. Now, these drugs are structurally similar to normal compounds within the cell and interfere with either purine or pyrimidine function by competing with the normal components of DNA and RNA synthesis. These are cell cycle specific and most effective in the S phase. So I think of these as sort of the spy doppelganger. So these are going to pretend like they're normal components of DNA. They're going to sneak their way into that DNA, and then they're going to impair the whole process and sabotage the DNA replication or synthesis. So the first one is methotrexate, very commonly used. So this is a folic acid analog, so similar to folic acid. It's similar to folic acid and acts by inhibiting dihydrofolate reductase, and some people refer to this as DHFR. Now, This converts folic acid to its active tetrahydrofolic acid form. And this leads to a reduction in compounds dependent upon folic acid, most significantly thymidine. And this leads to a decrease in DNA, RNA, and protein synthesis, and therefore causes cell death. So remember with methotrexate, remember it's very similar to folic acid. It's inhibiting dihydrofolate reductase, and specifically it's getting in the way of producing thymidine. Now, inhibition of the dihydrofolate reductase can be reversed with a 1,000-fold excess in dihydrofolate or administration of leucovorin. You'll hear leucovorin used several times in this lecture, and it's basically just folinic acid. Now, this replenishes the folate pool. So why wouldn't this get into the same problem as our original folic acid? Well, it bypasses this whole mechanism, so it does not require dihydrofolate reductase to be further broken down because it's already in further down in the process. Next, resistance. So resistance has developed, and it's usually developed by an amplification of the dihydrofolate reductase. There's also potential of decreased affinity of the DHFR for methotrexate, or by a decrease in the transport of methotrexate caused by a decreased pumping of methotrexate into the cell. So 1, we get more dihydrofolate reductase. 2, methotrexate can't really bind to the dihydrofolate reductase. Or 3, methotrexate can't get in the cell at all. So those are the 3 major resistances. Next, methotrexate is used in hematologic malignancies like acute lymphoblastic leukemia, in Burkitt's lymphoma, as well as sarcomas and choriocarcinoma. One of the benefits of methotrexate is that at high doses it can get through the blood-brain barrier, and therefore it can be given to treat CNS lymphomas, either primary CNS or metastatic disease. And then also interestingly, and you'll probably know this already, is that at much lower doses it's used as an immunosuppressant to treat inflammatory diseases like rheumatoid arthritis and psoriasis. Now, it can be given orally, especially when given in lower doses for inflammatory disease. And then it can be given IV, IM, and intrathecally, more so for chemotherapy reasons. Now for side effects, and it's going to have similar side effects to most of our chemotherapeutic drugs. Common toxicities like nausea and vomiting, stomatitis, myelosuppression, alopecia. It can also cause kidney failure, liver failure, pulmonary fibrosis, and then neurologic toxicities, especially when given intrathecally. Now, methotrexate is primarily renally excreted. It's hydroxylated to hydroxymethotrexate, which is poorly water-soluble and may precipitate in the renal tubules. So renal toxicity is a big deal, and it can be avoided by keeping the urine alkaline and thereby avoiding that precipitation. Other side effects can be decreased by administering leucovorin, as we talked about before, as a rescue, which is more readily taken up by the non-malignant cells, so it's protecting those non-malignant cells. Methotrexate is contraindicated during pregnancy, so this is one of those good medications that you need to remember. This is category X. You absolutely cannot give this to pregnant people. It is teratogenic, and it's used as an abortifacient as well. So for therapeutic abortions, we'll use methotrexate. All right, moving on to our next medication. Pemetrexed is the next one. It's very similar to methotrexate. It will inhibit dihydrofolate reductase, but probably more specifically, it's going to inhibit thymidylate synthase. So remember how this is a little bit different. It's not just dihydrofolate reductase, it's thymidylate synthetase. And it's transported into the cells by folate carriers, very similar to methotrexate. It's used in the treatment of mesothelioma. This is another association I want you to make with this medication. Mesothelioma is its primary use, but it can also be used in non-squamous types of non-small cell cancer as well. It's given IV and excreted in the urine. Prior to starting pemetrexed, B12 and folic acid should be given to decrease the toxicities. And otherwise, it's pretty similar to methotrexate.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide. Hi, I'm Dr. Mike McInnes, and we're going to go through the answers to the quick review number 1 in your study guide. So the first question, how does chemotherapy contribute to cancer therapy? So chemotherapy can be used concurrently with radiation, as a radiation sensitizer. This is called concurrent chemoradiotherapy, or CRT. Chemotherapy can also be used to supplement surgery and radiation in hopes to eradicate micrometastatic disease. These are cancer cells that escape the local area and are not removed by surgery. So you may think, we got all the cancer, we only found one tumor on CT scan, we went and took that tumor out, but you're thinking this tumor has a high rate of metastasis, it metastasizes early, there may be tiny microscopic metastases that we just can't see on scans, so we want to go ahead and give chemotherapy to try and eradicate those metastases before they have a chance to grow. The other use for chemotherapy is in palliative therapy to reduce the tumor load and increase life expectancy. Next, what is anti-angiogenesis? Well, this is a form of drug therapy, a form of chemotherapy that attempts to cut off blood supply to growing tumors by inhibiting the growth of new blood vessels. Angio is blood vessels. Angiogenesis is growing new blood vessels to supply blood and oxygen and nutrients to the growing tissue. So if you can block that development of new blood vessels, you can choke off the supply of nutrients to the tumor. Next, is chemotherapy more effective at treating tumors with a higher growth fraction or a lower growth fraction? Well, this is an important concept to understand. The answer is a higher growth fraction. These are tumors that are growing faster, dividing more. If a tumor has stopped growing, it's obviously harder to kill. Of course, cancers don't stop growing. That's what makes them cancers. It's just a matter of whether this is a slow-growing cancer or fast-growing cancer. So remember, a higher growth fraction will be easier to kill with chemotherapy. Next, what is a common mechanism that cancers use for resistance to chemotherapy? So this is amplification of P-glycoprotein. This is a pump that pumps drug out of the cell. So as cancer cells make more of these pumps, the chemo drug is going to be less effective. Next, what should be given prior to administration of pemetrexed to decrease toxicity? So there are two vitamins here, vitamin B12 and folic acid. Remember those. Next, what's the mechanism of action for methotrexate? Well, methotrexate is a folic acid analog that inhibits dihydrofolate reductase. This is going to decrease DTMP, which is deoxythymidine monophosphate, and you're going to decrease DNA and protein synthesis. Next, antimetabolites are most effective in what phase of the cell cycle? All right, let's review this because it may have been a while since you've thought about this stuff. The cell cycle has a short M phase, which is where you get mitosis and cell division, or cytokinesis. And then you have a long interphase, which is basically everything that happens between M phases. The interphase is subdivided into a G1 phase, and an S phase, and a G2 phase. Now the G1 and G2 phases, the G is for gap, and it's during the G phases that the cell is growing. The S phase is for synthesis, and that's when DNA is synthesized in anticipation of mitosis and cell division. So we just said that antimetabolites such as methotrexate decrease DNA and protein synthesis. So they're most effective during the S phase, which is when you have DNA synthesis going on. Next, what are some non-neoplastic uses of methotrexate? So methotrexate is used for cancer chemotherapy, but it's used for a lot of other things too. It can be used for abortions. If you need a therapeutic abortion for whatever reason, there's a risk to the mother's life or something like that. It can also be used to treat ectopic pregnancy. Again, you're trying to abort the pregnancy because it's not a viable pregnancy and it's very dangerous to the mother's life. It can also be used to treat rheumatoid arthritis and psoriasis and psoriatic arthritis. Next, what are the key clinical differences between low-dose and high-dose methotrexate? So when we're talking about low-dose methotrexate, often we use low-dose methotrexate for rheumatoid arthritis, psoriasis, and some malignancies. Low-dose methotrexate is given orally, usually once a week. You have 2.5 milligram pills, and you might say take 2 pills once a week on Wednesday or on Monday. It doesn't matter what day of the week, as long as they take it the same day of the week every week. I've seen some practitioners say, well, you're going to take 3 pills a day, so I want you to take 1 on Monday, Wednesday, and Friday. And that seems to work okay too. But for the most part, it's a once-a-week dosing. In patients who are getting low-dose methotrexate therapy, you need to monitor liver function tests, you need to monitor renal function, and you need to monitor CBC on a regular basis. Because myelosuppression is often the dose-limiting toxicity when you're using low-dose methotrexate. Now, high-dose methotrexate is a different beast entirely. High-dose methotrexate is used for leukemias and lymphomas and osteosarcomas. High-dose methotrexate is generally given IV, so you need to put in a central line. This is usually done as an inpatient to monitor urine output, to manage nausea and vomiting. You have to adjust the dose of the methotrexate infusion before you give each infusion. You adjust the dose based on creatinine clearance, so you have to do some studies. You also have to hydrate the patient aggressively, and we usually alkalinize the urine with sodium bicarbonate. During the infusion, after the infusion, you want to monitor renal function and monitor electrolytes and monitor a methotrexate level every day. Now, with low-dose methotrexate, we never check a methotrexate level. Likewise, with high-dose methotrexate, you don't really worry about monitoring CBC because myelosuppression is not a problem, because with high-dose methotrexate, you're going to give leucovorin to prevent that myelosuppression. So there's big differences between low-dose and high-dose methotrexate regimens. There's also an intermediate dose methotrexate, which is used for gestational trophoblastic disease or molar pregnancies. That's the end of the quick review. Let's go back to Dr. Lewis.
Next, we're going to move on to the purine analogs. So the 4 purine analogs are 6-mercaptopurine, 6-thioguanine, fludarabine, and cladribine. So first, we're going to talk about the 6-mercaptopurine. So it's a purine analog, and it's used primarily as maintenance therapy for acute lymphoblastic leukemia. 6-mercaptopurine is converted to 6-thioinosinic acid, or TIMP. So that's something to remember, TIMP, by hypoxanthine guanine phosphoribosyl transferase. And we'll refer to that as HGPRT from here on out, because that just takes too long to say. So TIMP, which we just talked about, inhibits the first step of purine synthesis and blocks formation of AMP and xanthinic acid. So this TIMP is also converted to TGMP, which is phosphorylated to di and triphosphates and incorporated into RNA. And then the deoxyribonucleotides are also incorporated into DNA, which results in non-functional DNA and RNA. So let's recap. There's a lot there. So this TIMP inhibits the first step of purine synthesis. So we can't make our purines. And then ultimately, after some metabolism, it gets incorporated into RNA and DNA. So this is another one of our spies. It's going into that RNA and its DNA, and it's sabotaging everything. So resistance. It can be caused by a decrease in ability to form the nucleotide because of decreased levels of HGPRT. Remember, that was a really long one that metabolizes or enzymatically changes our initial medication. And then you can also have an increased dephosphorylation or metabolism of the drug. So you just break down the drug in the cancer cell. Now, 6-mercaptopurine is given orally, which is nice. It's metabolized by the liver by xanthine oxidase. So this is very important. Can you remember a drug that's a xanthine oxidase inhibitor? Remember, that's allopurinol, and we use that for gout. So if you're taking allopurinol, your 6-mercaptopurine should be decreased in these patients because you don't want to give a much higher dose of 6-mercaptopurine than you're intending with patients who are being treated for gout at the same time. All right, moving on. The primary side effect of these medications is myelosuppression. So remember that, very similar to our other medications. Hepatotoxicity is another big one, nausea, vomiting, and diarrhea. So remember those side effects for 6-mercaptopurine. Our next drug is 6-thioguanine. So it's also a purine analog and traditionally used in the maintenance therapy of acute myelogenous leukemia. Converted to TGMP, and this is similar to our 6-mercaptopurine, so that long enzyme that we talked about, HGPRT, is also taking care of our 6-thioguanine. Converted to di and triphosphates, which inhibit biosynthesis of purines and are incorporated into DNA, leading to cell cycle arrest. So remember the same sort of thing. We're inhibiting that biosynthesis of purines, but we're also going in and acting as spies and sabotaging that DNA. It's given orally and also results primarily in bone marrow suppression. All right, so that's it for 6-thioguanine. Fludarabine. So this is a purine analog used primarily in CLL, but also as second-line treatment in AML and non-Hodgkin's lymphoma. It's converted and taken up into the cell and then reincorporated into DNA and RNA, and it decreases the synthesis, of course, in the S phase. Resistant is by a decreased uptake into the cells and decreased affinity for DNA polymerase. It's given IV, excreted renally, It causes severe myelosuppression. This is probably what you need to remember most about fludarabine for test purposes. You'll have a drastic decline in CD4 counts, and therefore you'll put patients at risk for opportunistic infections such as PCP or PCP pneumonia, also known as pneumocystis jirovecii now, but we still call it PCP pneumonia. So for up for a year after therapy is discontinued. So you need to put these patients on appropriate prophylaxis for PCP. So if they're taking the medication, they need to be on prophylaxis, and then up to a year afterwards, you still have to keep them on prophylaxis. And what type of medication would you use for prophylaxis for PCP? Well, most of the time you're going to use your TMP SMX, also known as Bactrim. Next medication is cladribine. So this is the last purine analog that we're going to talk about, used primarily in hair cell leukemia, converted into a nucleotide and incorporated at the 3' terminus of DNA, which truncates DNA as well as inhibits DNA repair. So again, it's our spy going in and sabotaging that DNA. Resistance is similar to fludarabine. It's given IV and causes severe myelosuppression as well. So I think of cladribine and fludarabine as being pretty similar. All right, so now we're going to talk about pyrimidine analogs. And we'll talk about 5-fluorouracil, capecitabine, gemcitabine, and cytarabine. So 5-fluorouracil, you'll often see this written and spoke about as 5-FU. And it's a pyrimidine analog used in GI malignancies. So anytime you hear of GI malignancy, you're generally going to talk about a 5-FU, stomach, pancreatic, cholangio, colon cancers, but you can also use this for breast cancer, ovarian cancer, and basal cell skin cancer, so it's used pretty often. It enters the cell and is converted to 5-fluorodeoxyuridine monophosphate, or as I like to call it, 5F dump. So remember that one, it's a little bit easier to remember that way. Which competes with deoxyuridine monophosphate for thymidylate synthase, leading to a decrease in thymidine. So all that just to say we have a decreased level of thymidine now, and therefore we get decreased DNA synthesis. So it's metabolized by dihydropyrimidine dehydrogenase. So this is also called DPD. Now this is very important because 5% of patients have a deficiency or a complete lack of DPD, which results in severe toxicity in these patients. So if you give 5-FU to these patients and they don't have this dehydrogenase, you're going to get some serious toxicity. So there is a commercially available test to evaluate for a DPD activity. You should probably do that with your patients you're going to start on 5-FU. Now, also you need to know, commonly, 5-FU is often co-administered with leucovorin. So this is a little bit different. You know, we were just using leucovorin before with methotrexate as a rescue for toxicities. Well, in this case, leucovorin's actually acting as a helper in this situation. It's not trying to counteract what the medication is doing. It actually increases the effectiveness of 5-FU. Leucovorin helps inhibit thymidylate synthase. Moving on. Resistance to 5-FU occurs when cells are unable to convert 5-FU into that 5F dump that I talked about before, or have increased thymidylate synthetase levels. Now it's given IV or sometimes topically, and this is another good discrimination with this medication. You can give it topically for skin cancer. There's not a lot of medicines that we're going to talk about that we use topically, but this is one of them. So 5-FU can be used for skin cancer treatment. It's metabolized by the liver and the kidney. 5-FU causes some of the similar side effects that we've talked about already: nausea, vomiting, diarrhea, mucositis, bone marrow suppression. Fairly unique to 5-FU, and this is a good test question as well, is hand-foot syndrome. So at low-grade levels, it's characterized by just erythema of the palms of the hand and soles of the feet. But if you get at high enough doses, you can actually get desquamation. So you get desquamation of the palms and the soles as well. So remember that as being a major side effect of 5-FU. All right, capecitabine, we're moving on. So it's an oral fluoropyrimidine prodrug, which can be used instead of 5-FU for many GI malignancies and for breast cancer. So it's very similar in 5-FU. It's converted into 5-FU by thymidine phosphorylase, and its mechanism of action and resistances and side effects are very similar to 5-FU. So it's just basically a medication that it gets converted into 5-FU when it gets metabolized. Next medication is floxuridine. So this is an analog of 5-FU that can be given intra-arterially to treat GI adenocarcinoma that's metastasized to the liver. So if you get a question about metastasizing to the liver, this could be a good medication for that. So floxuridine is rapidly catabolized in the liver to 5-FU and then produces its anti-metabolic effects from there. Similarly to 5-FU, it interferes with the synthesis of DNA and to a lesser extent inhibits formation of RNA. Remember our spy going in and sabotaging. It's excreted in the urine. Side effects are nausea, vomiting, diarrhea, stomatitis, localized erythema. Nothing too interesting there. Cytarabine is our next medication. It's an analog of 2-deoxycytidine and is used in acute myelogenous leukemia. It's carried into the cell and phosphorylated to the nucleotide form cytosine arabinoside triphosphate, and this inhibits DNA polymerases. So this is probably the buzzword you need to remember with this medication. DNA polymerase is where this primarily acts. Results in a blockade of DNA synthesis and DNA repair, as well as inhibiting DNA elongation, and this is S-phase specific. Resistance occurs with decreased transport into the cell, change in the phosphorylating enzyme as well. It's given IV or intrathecally. It is inactivated to an inactive metabolite and excreted by the kidneys with a very short half-life. This is another thing you need to remember about this medication. Very short half-life. So you pretty much give it continuously, continuous infusion over 3 to 7 days. So with that very short half-life, you have to sort of keep pumping it in. It causes the common GI and bone marrow toxicity as well as liver toxicity. When given in high doses, it can cause irreversible neurotoxicity, and patients should be monitored frequently for this side effect. So you're having to give it continuously. Be aware of any neurotoxicity. Next is gemcitabine, analog of deoxycytidine, so similar to our previous medication, used for the first-line treatment of pancreatic cancer, but also in non-small cell lung and breast cancers, as well as lymphomas and sarcomas. So gemcitabine is phosphorylated similarly as our previous medication by a deoxycytidine kinase into difluorodeoxycytidine triphosphate. And this is incorporated into DNA, thereby inhibits synthesis. Gemcitabine also competes with the natural nucleotide substrate for deoxycytidine kinase, which decreases the natural nucleotide of DCTP, further affecting DNA synthesis. So in my brain, I remember this is getting into our DNA again, acting as a saboteur. Resistance is developed by a change in deoxycytidine kinase, which inhibits the conversion of gemcitabine to a nucleotide and increased levels of normal deoxycytidine, which can compete for the kinase and overcome inhibition. Gemcitabine is given IV, excreted in the kidneys. It causes our usual stuff: nausea and vomiting, myelosuppression. Primarily thrombocytopenia can be a big deal, and occasionally flu-like side effects. All right, so now we're going to switch gears. We're going to move over to antibiotics. So it's a little counterintuitive. We don't generally think of antibiotics as being able to fight cancer, but there are a few, and we need to talk about them. So there are a handful of antibiotics that have cytotoxic effects, and they act primarily by disrupting DNA, like what we've been talking about so far, but also inhibit topoisomerases 1 and 2. Now, what do the topoisomerases do? I like to think of them as the janitors of DNA. So they're not changing the sequence of DNA. They're going in, they're doing tucks and nicks, and they're connecting things together, but they're not acting on the primary sequence of DNA. Now, they are cell cycle non-specific and include dactinomycin, the anthracyclines, and bleomycin. So let's go over these. So the first group we're going to talk about is dactinomycin. Sometimes you'll have this referred to as actinomycin D, but for clinical purposes, most of the time you're going to see this as dactinomycin. Now, this is used in the treatment of Wilms tumor, sarcoma, and choriocarcinomas. It exerts its effect by intercalating into DNA between guanine and cytosine, which interferes with RNA polymerase. Now, it also causes single-strand DNA breaks. Now, the resistance can occur with that. Remember, we talked about this before, the P-glycoprotein-dependent efflux of the drug from the cell. So P-glycoprotein, always keep that in the brain. It's shooting stuff out of the cell. Now, it can be given IV. It's metabolized by the liver, and then it's excreted primarily in the stool. So this is not a renally excreted medication. It causes myelosuppression. You get nausea, vomiting, diarrhea, alopecia, the usual stuff. It's also a vesicant, so it can cause a lot of blistering and possible necrosis of the skin if it extravasates. So be careful of where you're putting in your IV. Next, we're moving on to the anthracycline. So this is doxorubicin, daunorubicin, epirubicin, idarubicin, and mitoxantrone. So all of those right there. So the anthracyclines are used in a wide variety of malignancies, including bladder, breast, and gastric cancers, as well as lymphomas and leukemias. They have several mechanisms of action. First, they will intercalate into the DNA non-specifically, thereby blocking DNA and RNA synthesis. So again, we're messing up our DNA. They inhibit topoisomerase 2, and remember we talked about those are the janitors. They bind the cell membrane, which affects cell transport, and they generate free radicals, and this is the different part. Free radicals is something you need to remember. Free radicals when reduced by the cytochrome P450 reductase. Now, they're given IV. They're also vesicants, so that necessitates they be given through a central line. They are metabolized by the liver and excreted in the stool again. Side effects include significant nausea and vomiting, alopecia, myelosuppression, mucositis, the usual stuff. Specific to the anthracyclines is a cumulative dose-dependent cardiotoxicity. So you have to remember this with these anthracyclines, is that cardiotoxicity is its unique side effect. It's thought to be a result of the formation of free radicals. Remember I told you to remember the free radicals? This is killing your heart while you're taking these medications. So it's free radicals within the cardiac tissue, and it can result in an irreversible congestive heart failure, or cardiomyopathy. And therefore, there is a maximal dose of anthracycline that anyone can take in their lifetime. So there's this max dose, and you can't go above it. Even if you have more treatment that's needed for your cancer, you can't go above this, otherwise you're going to kill your heart. So as a result, cardiac function must be evaluated prior to giving the anthracycline and throughout the treatment course. So the things to remember about these, of course, remember those free radicals and remember the cardiomyopathy. Next, bleomycin. So this is used in testicular cancers and lymphomas. It binds DNA and iron and is oxidized, and this results in, again, free radicals that cause DNA strand breaks and chromosome changes. Resistance occurs with increased levels of hydroxylase or increased DNA repair. It's given primarily IV, though it can be given subcutaneously or intramuscularly, which is unique to this medication. It is inactivated by bleomycin hydrolase, which is present in many tissues but lacking in skin and lungs, and this becomes important here in a minute. Bleomycin is excreted into the urine. So the most concerning side effect specific to the drug is pulmonary fibrosis. So if you remember bleomycin and pulmonary fibrosis, you're bound to get a question on that at some point. And this is permanent and can be life-threatening. Therefore, lung function should be tested before, during, and after treatment with bleomycin. Now, it can also cause an anaphylactic type of reaction with fever, chills, and hypotension.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
What is the most serious adverse effect of doxorubicin? Cardiotoxicity. That's why we always check ejection fraction before starting therapy and monitor for changes during and after treatment. Not that you need to know that after you flunk out and transfer to truck driving school. Hey, you can kill people there too.
All right, let's go through the answers for quick review number 2. First question, list the purine and pyrimidine nucleotides. So this is a very basic review, but let's remind ourselves of these because it may have been a while since you thought about this stuff depending on where you are in your career. So the purines and the pyrimidines, the nucleotides, are the basic building blocks of DNA and RNA. The purines include adenine and guanine. The pyrimidines include cytosine and thymine in DNA, and instead of thymine in RNA, we use uracil. So guanine pairs with cytosine, adenine pairs with thymine in DNA, adenine pairs with uracil in RNA. So like Dr. Lewis says, if you use a purine analog or a pyrimidine analog, it's like a spy that infiltrates the cancer cell and gunks up the replicative process. That's the primary problems with neoplasms. The cells are undergoing abnormal replication, and they're not undergoing normal apoptosis. So we can actually stop that process with these analogs. Next question. If you have a patient being treated with allopurinol for gout, what chemotherapeutic agent must be reduced to avoid toxicity? This is 6-MP, or 6-mercaptopurine. Very important to know that. It interacts with allopurinol causes big problems. Next, what types of cancers can be treated with 6-MP? So leukemia, especially ALL, some pediatric non-Hodgkin's lymphomas. It's also used not for malignancies but for IBD, inflammatory bowel disease such as ulcerative colitis and Crohn's disease, and it can also be used to treat primary sclerosing cholangitis. Next, what pyrimidine analog can be given topically to treat skin cancers? So this is 5-fluorouracil, 5-FU. Next, how does resistance occur with 5-FU? So resistance occurs either when cells have lost their ability to convert 5-FU into its active form, which is 5-F-dump, as Dr. Lewis calls it, or when cells have altered or increased thymidylate synthase levels. Next, what enzyme converts capecitabine into 5-FU? Well, this is thymidine phosphorylase. Next, how do anti-tumor antibiotics work? So they disrupt DNA, and they can also inhibit topoisomerase 1 and topoisomerase 2. Next, what is one important and unique side effect to remember about anthracyclines, and what's thought to cause this? Well, the unique side effect you need to remember with these is cardiomyopathy, and it's caused by the formation of free radicals. The cardiomyopathy from these anthracyclines is irreversible, and it's also dose-dependent, so there's a maximum lifetime dose of these drugs that you can give. Next, what study must be done before starting doxorubicin, or the brand name is adriamycin? Well, adriamycin is one of these anthracycline drugs, so you're worried about the development of cardiomyopathy. And before we start doxorubicin, you want to determine the ejection fraction to establish a baseline to compare against when monitoring for cardiomyopathy. Now, we usually determine this ejection fraction with a MUGA scan. MUGA stands for multi-gated acquisition scan. So you do a MUGA scan. Basically, you inject a radioactive marker, usually technetium, and then you measure the amount of the marker that's in the heart during diastole and during systole. And if, say 60% of the technetium is ejected during systole, then the ejection fraction is 60%. So this is going to give you a very precise, numerical, quantifiable ejection fraction. Unlike the echocardiogram, which is how we typically determine ejection fraction for patients with cardiomyopathy, congestive heart failure, lots of other diseases we want to do an echocardiogram, we can estimate the ejection fraction, but it's very reader dependent. Some cardiologists may look at that and say, well, this ejection fraction is 45%. But how do you determine 45% versus 55%? 55% is normal. 45% is kind of getting into the low end of normal. How do you determine between 20% and 30%? It's very difficult with an echocardiogram. With a MUGA scan, you get a precise number. Next question. What are the adverse effects of bleomycin? So bleomycin, you have to remember, bleomycin causes pulmonary fibrosis. Very, very important, very, very testable. Bleomycin can also cause anaphylactic type reactions. It can cause fever and chills, and it can cause hypotension. That's the end of the quick review. Now I want you to pause the video, answer the end of session quiz questions, then restart the video, and we'll go through these answers together.
Which cancer drug works by causing oxidation and breakage of tumor DNA and notoriously causes pulmonary toxicity, including fatal pulmonary fibrosis? Bleomycin. It can also cause skin toxicity and fevers, but does not usually cause marrow suppression. Somebody has been messing with my lights again. What is wrong with you people? There. Nurse, I want an incident report written up and ready for me to sign. I will not tolerate people moving things in my OR. Heads will roll.
All right, let's go through our answers to the end of session quiz. First question, name 3 advantages to combination chemotherapy. So combination chemotherapy provides maximal cell killing within the range of tolerated toxicity. Combination chemotherapy is effective against a broader range of cell lines, and it may delay or prevent the development of resistant cell lines. Next, the antimetabolites are structurally related to normal compounds like purine and pyrimidine nucleotide precursors. Generally, they interfere with the synthesis of what? They're going to interfere with the synthesis of RNA and DNA. Next, methotrexate is similar in structure to what vitamin? Well, it's similar to folic acid. That's why we give folic acid to patients who take methotrexate to prevent some of the toxicities such as myelosuppression. Next, which chemotherapeutic agent can cause erythema and/or desquamation of the palms and soles? Well, this is called hand-foot syndrome, and we see this with 5-fluorouracil. Next, allopurinol can increase the serum concentration of what chemotherapeutic agent? Remember, we said this is 6-MP. We've mentioned this 3 times so far in this lecture, so you really need to remember that. Allopurinol, 6-MP. They don't play nicely together. Next, which class of chemotherapeutic agents can cause irreversible cardiotoxicity? Remember, this is the anthracyclines, especially doxorubicin and daunorubicin. Epirubicin and mitoxantrone are less cardiotoxic. They can still cause some cardiotoxicity, but in general they're less cardiotoxic. Next, why do chemotherapeutic agents affect the GI tract, bone marrow, and hair more than other cell types and organs? Well, chemo agents primarily affect rapidly proliferating cell types. So all these tissues are rapidly proliferating, so chemo is going to affect them as well as affecting the tumor cells. Next, which chemotherapeutic agent is used at lower dosages to treat inflammatory diseases? Well, this is methotrexate. We talked about how it's commonly used to treat rheumatoid arthritis. Next, which anti-tumor antibiotic is used to treat Wilms tumor in children? Well, this is dactinomycin. And the last question, match the drug with its characteristic. 5-fluorouracil is often used in GI malignancies. Methotrexate inhibits dihydrofolate reductase. Doxorubicin causes dose-dependent cardiotoxicity. 6-mercaptopurine is metabolized by xanthine oxidase. Bleomycin causes pulmonary fibrosis. And leucovorin reverses the adverse effects of methotrexate. All right, that's the end of the end-of-session quiz, and that's the end of our lecture on anti-cancer drugs